was very good. And Dr. Fleming, what are your thoughts on that and herd immunity? Who's going to get better anyway versus who should be treated with these medications and when?
Right, and the reality is we don't really have data on herd immunity on this virus, do we? So it's always nice for people to use that as a distraction talking point when they're trying to confuse the general population. Dr. Zelenko is on target when he says we need to treat the ones that are actually having the inflammothrombotic consequences. And as you can see, from behind me, we have our method for FMTVDM of actually measuring the tissue changes and the 4 critical steps that need to be looked at for the treatment of this virus. And the first one is the virus infecting people and is it able to replicate people? To which Dr. Zelenko has published a considerable amount of data, as have the people at Henry Ford Hospital and some other individuals throughout the world looking at the ability of the drugs that are available to interfere with the replication of the virus, including, as I've mentioned before, azithromycin. This drug is usually used, people think, to prevent secondary bacterial infections. But if you look at the medical literature, the research that has been done, azithromycin has been used to successfully treat Zika virus, where it has been demonstrated to interfere with the replication of the virus and to improve the viability and replication or continued growth of the glial cells in individuals that were studied. So the theories that antibiotics like azithromycin and the other macrolide antibiotics that we use can only work in bacteria and won't work in human cells is debunked by that research. And so the combined use of that with hydroxychloroquine has reason to demonstrate from Zika virus, which the WHO still says there's no cure for. So I'm not sure how valid we can depend upon them for what they're saying. But, above and beyond that initial phase, then we look at the secondary phases of oxygenation and how to treat patients and how to not cause more inflammation by incorrect use of ventilator settings. And then we have to realize that the immune response kicked in immediately. But by the time several days have passed, the initial cytotoxic component with the release of the chemicals from our cells communicating to other cells to let us know that we need to respond to this infection. Interleukin 6 is the classic one, but there are others. And then the latter 7 to 10 days humoral antibody response, those all have to be taken into account. You know that my preference is, particularly in the hospitalized setting, to use FMTVDM to actually measure results. But I would say that just because the patient gets put on hydroxychloroquine and azithromycin or some other combination and zinc and ends up in the hospital does not mean that those drugs failed, because you never know whether they would have been worse to begin with or not. What you know is that the problem is continuing and perhaps getting worse. So the way that we've structured it is to begin these drugs in the protocol and then to add to them the additional drugs that are necessary. And to use the example I started with earlier with the cancer patients, when I trained as an intern, my first year as an intern, and I was on my oncology ward rotation, I lost 3 cancer patients. And I felt devastatingly bad about those 3, but that was a record low. And when people ask me why so few of my cancer patients died, it wasn't because of me, it was because of the oncologist who trained me. And he said, Fleming, when these cancer patients come in and they become febrile and you don't know what the infection is, they have cancer and they will die. You begin with these 2 antibiotics, period. And if 36 hours later they have not improved, you will add this antibiotic, period. And if 36 hours later they have not improved, you will add this antifungal, period. And if 36 hours after that they have not improved, you will add this antiviral, period. That's why those people survived, because I didn't have the luxury, and neither did they, to wait for a test to come back to confirm We did it based upon what kills those patients. And what kills COVID patients is not so much the virus as the response to the virus and this inflammatory response that is to be expected and normally is in balance because we're dealing with healthy people. But with the naive, the immune naive, the very young, or the immune deficient, or with those who have all these chronic diseases where they are already geared up for a hyper-inflammatory response, they are the ones that will suffer. And waiting days is not an option.